We'll start and request Raju to start.
Yeah. Thank you very much, sir. Thank you for giving me an opportunity to be a part of your IC. Pranams to my teachers on the dais and to the audience. I'll be sharing with you how I would treat a chronic CSR with a central leak. It's a very focused topic that sir has given me. Well, we all know that CSR is the fourth commonest non-surgical retinopathy associated with fluid leakage, and it was termed as central recurrent retinitis and later termed as central serous chorioretinopathy, letting us know that the choroid is also involved in the pathology of this disease. Most cases of CSR resolved, but however, some become chronic, leading to persistent visual problems, RPE atrophy, and recurrence. But what is the definition of chronic CSR? Actually, it's very confusing. If you go by this classification, they are classified as non-resolving CSR, recurrent CSR, chronic CSR, and inactive CSR. And non-resolving or persistent CSR is classified as something that is lasting more than 4 months. And the chronic CSR and persistent CSR, again, they have made a differentiation. Chronic CSR is only when you have a widespread RPE atrophy or with neurosensory retinal detachment. So they have made classification between, again, chronic and persistent according to this study. And when you go back and see the various studies, each study has taken a different criteria. So how do I classify my case as a chronic CSR? Most studies have taken it as 3 months. And probably persistent cases and chronic cases are all clubbed together. So there is a lot of confusion in the terminology itself. So to overcome this, the Central Serous Retinopathy, Chorioretinopathy International Group published the criteria for CSR into major criteria and minor criteria. The major criteria are the presence on evidence of prior SRS, and at least one area of RPE alteration on fundus autofluorescence or on OCT or infrared imaging. And they also had a minor criteria, which is on ICG or FFA leak being present and choroidal thickness. So these are the various criteria that have been proposed to maintain uniformity in our diagnosis. So now they have classified CSR as simple and complex and atypical. And again, from there, you are again subclassified as primary, recurrent, and resolved. And anything where the SRF is persisting more than 6 months is now called as persistent. Now, all of them can be associated with RPE atrophy or with a CNVM. So this is the current classification to maintain uniformity across all sectors, all studies. They have proposed this classification, and probably we may have to use this classification going forward, which means to say that persistent is the one which would be termed as a chronic CSR. So this is how it will be. Classification would be a simple CSR and a complex CSR. Persistent is the one which is more than 6 months of SRF being present, with or without RPE atrophy or with or without CNVM. This would be the new terminology. Now, how do you manage these cases? So now again, we have to go back to the pathophysiology. This is the basic pathophysiology that we are all very much aware of chronic CSR, wherein there is a choroidal thickening, vascular congestion, altered blood flow, and choroidal hyperpermeability. Now, this is what, as a basic, we started. But if you look at it, this is a very busy slide. So this is all the various pathophysiology that can be involved in the CSR, and we may have to look at all these things because it is a chronic CSR now, not acute CSR, because we may have to rule out each and everything. And probably most of the times we are looking at this aspect wherein the corticosteroid induced or stress induced is the one that we are looking, but there are various other causes which might be leading to CSR. Now, that's why we need to take a good history. So the good history includes you need to rule out the use of any drugs, then look for endogenous and exogenous causes. Some other causes like sleep apnea has to be considered, The end-stage renal disease also is one more disease which can lead to a chronic disease. Cushing's disease, again, can be a first presentation of CSR, and that should be ruled out. Then, in these cases, we may require additional tests. So, chronic CSR patients, I may consider doing a serum cortisol levels, testosterone levels, platelet function tests. Sleep studies I have not yet done, but may need to consider them. As far as the additional tests, ocular tests that are concerned, we may have to do an enhanced depth OCT, then ICG and OCTA. These are the three investigations that would be required in these cases. Another thing is a good clinical examination. This was a case referred as non-resolving CSR and ended up actually having an optic dysplate. So the OCT will give out the diagnosis, but you need to look for the optic dysplate in these cases whenever you suspect a patient of persistent CSR. The typical ink blot leak and the smokestack leak is not seen in these cases. These cases usually have a more diffuse disease with lot of RPE atrophic traps, and hyperpigmentation and hyperplasia may be seen in these cases, and gravitational teardrop and hourglass shape you may see on the FFA and OCT. In the OCT, again, you have a very diffuse disease, a shallow or a flat PED will be there, then hyperreflective detached photoreceptors may be seen underneath in the lower part, the outer retinal layers. And very chronic cases, you may see thinning. Autofluorescence actually gives you a better picture, showing you a wider range of the disease activity, and especially the shortwave, the infrared is better than the shortwave conventional FAF. Enhanced depth, again, you'll be able to see the increased depth in the increased thickness, choroidal thickness, and ICG-A is one investigation that I would like to get it done in these cases, wherein we can see that mid-face hyperfluorescent plaques will be seen in these cases, and OCT-A can pick up this macular neovascularization, which can be leading to chronic fluid leakage in these cases. We may also have to rule out PCV in these cases, which may mimic something very similar to chronic CSR. The aim of the treatment would be complete resolution of SRF, preserve the photoreceptors, improve visual function, and prevent recurrences and disease progression. So we always look at some treatment options that includes the psychotherapy, then the pharmaceutical treatment and the lasers would be used in these cases. As far as the medical treatment is concerned, most likely we'll be using the eplerenone in these cases. The other mainstay of treatment would be the PDT and the lasers. So this is how we usually treat acute patient comes to us with CSR. Most of the times we observe these patients for about 4 to 6 months. If most of them would resolve spontaneously. If they don't resolve, then I would go ahead and do an ICG and OCTA in these cases and rule out a CNV and then plan accordingly. So this is how we would look at. So observe for 4 months. If this is not responding, then we go ahead and do the ICG in these patients. ICG and OCTA would be required. Okay. So as far as treatment is concerned, previously when we had the availability of PDT, half dose vertiporfin PDT was better than subthreshold laser according to the studies, and this is now not available. Then when compared with eplerenone, again PDT is better. But however, the PDT had these risks. If anybody has access to PDT, then this is the best treatment that is available for these patients. As far as micropulse laser is concerned, this is to be done in a targeted way for the hyperfluorescent areas that are seen on ICG. Some of us also paint the whole CSR area using this duty cycle of 5% and pulse duration of 200 milliseconds. And this works, is said to work in about 17 to 20% of the patients. However, what they found was there's no influence on disease recurrence and no difference to the choroid was seen with laser photocoagulation. As far as antioxidants are concerned, again, did not show any benefits. However, the fluid reduction happened slightly faster with antioxidants. Eplerenone, again, we all been using it with success. I'll show you my cases, but this was not found to be superior to placebo. So eplerenone was no better than placebo. So these are my few cases wherein this was a patient who had an exudative CSR kind of a picture for 3 months, and treated with eplerenone, he responded quite well. This is another patient who responded to eplerenone. Most of the cases I had started with eplerenone to begin with due to lack of access to PDT, and he responded to eplerenone, but however, he came back later with a detachment again, which was found to have a CNV or a macular neovascularization, and this was treated with ranibizumab biosimilar. However, he continues to require injections on and off in these patients. This is one more patient treated for MNV. So the take-home points is that we may have to adopt to the newer classification, and the CSR is will have these atrophic changes. We need to look for this, and multimodal imaging would be the mainstay of treatment to help us to find out the PCV, rule out PCV, and to find out a macular neovascularization. So the best option would be still a vertiporfin, which is not available, and the other two options that we have in our hand are the micropulse laser and the eplerenone. And for chronic cases with MNV, anti-VEGF injection would be required. Thank you.
Do we have any questions from the audience?
Thank you, Dr. Raju. Yeah. Any questions from the audience? Yeah.
Usually, to begin with, we start with 25 mg and look for hyperkalemia. So before you start the patient, you do electrolytes, serum electrolytes, and look for hyperkalemia. Then if he's tolerating, I increase it to 50 mg. Then continue it for around 1 to 1.5 months. Then try to taper it if the patient is doing well. Then get him off. So usually around 2 to 3 months is what I usually would give.
Yeah, but the basic problem with eplerenone is when you taper it off, it often comes back. So, and this is the problem with all the other things also. Even rifampicin, say it works in some cases. Yes, that's anecdotal. You stop the rifampicin, it comes back. So this is not the answer really.
But it can be used for several months. To answer your question, it can be used up to a year or two also, if the patient is able to tolerate.
And the only thing is that this toleration requires a constant check on hyperkalemia. So you have to have a serum electrolytes done on a at least weekly, 2-weekly basis to make sure you don't end up with a problem there.
So, like, why this PDT not available nowadays? Like in all CSR sessions,
It's not,
we hear it's
PDT is off patent.
It's not, the Novartis company has stopped manufacturing Visudine.
So they don't need to do.
There is a
Yeah, but
global
as
shortage
of now, there is no Visudine available. I think there's a localized stock available with Arvind.
No. In Coimbatore, people are sourcing it from the Middle East, but that's and that also there is some company in Germany, I think Chapla Pharmacy or something, but it's a very vague route of procurement of the Visudine. It's not Visudine. Actually, it's a different drug completely.
Yeah. So as of now, that's not available. But keep in mind, see, every CSR does not need intensive treatment. If your patient has 6/6 vision, you don't have to be very aggressive on that. It's going to be a long-term disease. Giving treatment which is not going to alter the course doesn't matter. I mean, I have patients who've been there for years without treatment. You're talking of years with treatment. I'm talking of years without treatment. Vision is 6/6. You leave them alone. You don't have to touch them. It's the reason for touching, and my indication for touching is if the patient has intraretinal cystic cavities in the macular area. These patients respond to treatment. They respond to anti-VEGF treatment. Similarly, if these patients have fibrin deposits, what looks like Shrem, this is not a CNVM, it doesn't show up as a CNVM on OCT angio, but that is an inflammatory component which responds to anti-VEGF. So other than a CNVM, which is another factor which can happen in these patients and which definitely needs treatment, these are two other situations in a chronic CSR where I would consider giving an anti-VEGF. And I find Eylea works better than ranibizumab for this situation. Any, would you like to?
Put things in perspective, one option which you mentioned is subthreshold micropulse laser. Now this is breaking up that laser beam into smaller parts, and I'll probably briefly touch upon that in my talk too. So that you're not doing any RP thermal damage. Okay, so this is photosensitization. So that is a modality which can be used, and we've used quite successfully, and he showed that publication also. I'm part of that SOLS international study group. So that is a very viable option. Another option, left field option, is if you have extramacular, and I'm repeating that, extramacular. Another option is titrated low dose transpupillary thermotherapy, which is basically using your red laser, 810 nanometers. Okay, the only way where Dr. Dinesh Talwar was saying about anti-VEGF, there's a lot of discourse about that. The way situation where it can work, the reason for it being working is choriocapillaris ischemia is caused in chronic CSR. So that component can be cut. But whether anti-VEGF is a panacea for CSR, answer is no.
Also, I would suggest an OCT angiography at first visit to rule out CNVM, because then it would respond very well to anti-VEGF. So OCT angio, if it is accessible, should be done for every CSR at first visit to rule out CNVM, which would respond to anti-VEGF very well.
Thank you.
Hi, how are you? Thanks for coming. It can be tried, but that would be anecdotal response. But it can be tried and it may work.
Some patients respond well. You give 125 milligram acetazolamide in 2 doses for 2 to 3 weeks. They respond well.
Yeah, that's what I'm saying. It's anecdotal. Yes, it can.